I think we're ready.
Hello, Dr. Tom.
Oh, and how are you?
Wonderful.
Yeah, you're looking great.
Did we find Leanne?
Yep, I think we're ready to begin.
Good morning. Good afternoon, Leanne.
Hey, yes, I want to just say a word or two. This is Tom Odoricio, and I'm honored to work with all the virtual participants for the NCAN session, and it's going to be a very, very interesting and exciting afternoon. And our first speaker is Leanne Burns, who's I had many years at Louisiana State University and has a book on nutrition, probably the nutritionist of the decade when it comes to carcinoid and neuroendocrine tumors. And I'm anxious to hear because I always learn 5 or 6 new things. So, Leanne.
Thank you, Dr. Odoricio. Dr. O, as I would say.
Okay. So, Leanne, I'll be asking you a few questions, and then you could add on if you find anything that needs to be expanded. So, as a dietitian, what is your biggest concern when treating patients with neuroendocrine tumors and why?
The biggest concern we have as dietitians is malnutrition and malabsorption. These two things can create many of the problems that we have with our bodies and with being able to fight the immune systems, as well as keeping the things we know up to par, like our weight and our protein status. The neuroendocrine tumors in themselves create an environment that can reduce the absorption of nutrients because of the symptoms that are associated with it. This can be from the tumors themselves, the treatments that we have to use, the medications we use, the surgeries that you may be going through. And we're always finding these new treatments. So we'll continue to have to work with the symptoms that may be creating some of the problems we have, such as unintentional weight loss, a reduction in our protein statuses, and vitamin and mineral deficiencies. And these can be very common in patients with neuroendocrine tumors.
Oh, thank you. Are there any nutrition recommendations special for NET patients?
There are some recommendations that we have. Neuroendocrine tumors are very different in some ways than other areas of cancers that we treat. Because of the problems that we have with absorption, we have to tailor diets so that they can be in a form or in a reduction of some macronutrients such as fats or carbohydrates, or we may have to change the protein so that we can get a better absorption. So some of the recommendations that we have are that we need a little bit more protein in our diets, and these can come from animal proteins. We're not afraid to use that, and they're very important, especially when we're replacing niacin areas. Animal fats, plant proteins, which are also very important, and we can work these in as well. Some of the other things that really are troublesome are the intakes of fats. Fats come in different forms and fashions, and sometimes we hear them, some of them being healthy and some of them not as healthy when we talk about heart disease. But when we talk about fats and neuroendocrine tumors, we're really worried about the symptom of steatorrhea, or not being able to digest the fats. And this will increase the output of stool. And it also can bring important nutrients that are also in those fats and push them through the system unabsorbed as well.
So can I ask Marianne a question?
Oh, right ahead.
Leanne, thank you. Are there any over-the-counters that in a carcinoid patient symptomatic that can worsen their symptoms?
Over-the-counter medications?
Herbs or spices.
Yes. Now, we do not encourage supplementation of by herbal areas of supplements. And I'm not talking about the greens that we grow, because people have heard me speak. No, I love to use those kind of things in your cooking. I'm talking about the kinds that are in the pharmacy or at the drugstore that come in in containers. Some of these herbs can actually cause lots of symptoms and also complications with some of the chemotherapies that we use. St. John wort is one example of that, but there are many, and we don't really know. There's no regulations of the FDA supplementation in the States, and so just because someone says it's good, or just because they say it's in this bottle at this amount, there's not a quantitative way to check what's there. So we really do not encourage that. But if you are going to take something, because we know that in oncology people like to take something, so if you're going to do something, please talk to your physicians, to your healthcare team, or to me if I'm taking care of you, and let me know, and so that I can really give you better guidance. But the toxicities related, and that you already have troubled livers, the less we do to put anything through the filtering systems we have is probably the best choice.
Yeah.
Great.
Thank you.
What's the best diet for a peanut to follow?
Peanuts are, we know that they're different and very unique in their own way. And so there's a couple of things that a peanut that's had surgery and had a Whipple will need to change the timing of their food, especially post-op. We have a diet for Whipple patients where we separate the foods from their liquids by 30 to 45 minutes. And this will help reduce the transit time. That means the time that things leave the GI tract, go through the stomach to the GI tract and on through. It's also very important that they reduce the concentrated sweets. And when we say that, we mean sugars in a drink, whether it be fruit juice or a Gatorade, in a electrolyte something, or a cola. These things that have a high concentration, and those are things, if you look at a label, are above 12 grams of sugar. So if you look under the carbohydrates, you're going to see where it says sugars, and you want that number down around 5. 5 is pretty easy to tolerate. So those are some of the things that we really do. We also want some of the research coming out of Europe now is saying that we need to do a better job of maintaining weights and glucose control. And I think that that's the biggest thing for peanuts that's different, because they're not going to be working with as much GI problems. They probably will need a pancreatic enzyme or something for the fat malabsorption that's related to this. But it's good glucose control, being treated much more like a diabetic, and the management of a diabetic would be, is what I believe we need to really stress.
Okay.
And work with their symptoms. That's how we do everybody. We take those symptoms and go from there.
You just said about the pancreatic enzymes. Will you just tell us how they work and why they're important? Okay. And are they important for a GI net as well, who's had a resection? Anytime that we have malabsorption of nutrients, whether it be protein, carbohydrates, which are in your breads, your starches, or as fats, then we have enzymes in our bodies that are released that help break these down. When we are using for surgical reasons or for medication side effects that are very important in the use and the treatment of these tumors, sometimes we're going to suppress the output of these pancreatic enzymes normally. This will require us to have someone take these when they eat, timed pretty close to their eating, so that they're there to help digest these foods. Fat being one of the biggest ones, and then that's very important because that is lipase. It's the enzyme that digests fats in our body, and those are the numbers when we see these. If you have them ordered, you'll see them at different levels, and that's the lipase levels, and that's how much fat we need to digest the fats in your diet. It's important to digest fats because we need the nutrients in them. And sometimes we need the weight to be maintained. And we know those calories from those fats are important for us. So they're not all alike. We do have over-the-counter digestive enzymes. Sometimes when we do try these in practice, I think most of us try these.
These are more based at carbohydrate malabsorption in higher amounts, and they can help with protein, mainly with the fruits and vegetables, but they can help with some of this gas. Carbohydrate malabsorption is very gassy. And so you can try those and see if they work before you get into the prescriptions. But more times than not, if you're having that floaty foul stool and you can see the fat in the toilet or something, droplets, then you're probably going to need a pancreatic enzyme. And I think Dr. Odorosio will be a physician to back me on this. I like to speak with physicians to at least give me some acknowledgement here.
No, I'll just follow up with your great discussion, Leanne, and that is, it's a given that with either lanreotide or octreotide, you're going to have meal-stimulated fat malabsorption, in addition to the endogenous issues that go on. And a lot of times we tend to forget that the fat, it's called subclinical, fat malabsorption can be a real issue over time, especially with the long-acting forms, the LAR and the depot. So it's what you're talking about has great application just in terms of the monthly injections, and they're often forgot. If you go back historically, the gastroenterologist had a great deal of difficulty communicating with medical oncologists about the fat malabsorption that you can get, from octreotide. And it's just a mechanism of octreotide to suppress meal-stimulated, the fat, particularly the lipase. And your discussion, though, on the carbohydrates is very important as well, because that gas is really an issue a lot of times. And you tend to lump it together with, lipase insufficiency. The other thing with the fats are the fat-soluble vitamins. And, A, D, E, and K, particularly D, can be an issue. I think you'd agree.
I agree wholeheartedly. I think that one of the biggest problems we have in nutrition is keeping these levels of minerals up. Calcium, vitamin D get overlooked quite often. But the fat-soluble vitamins, much like some people may be familiar with a disease in children called cystic fibrosis, where we have problems with fat malabsorption. So I think we had to really learn off of that, Dr. Odorosio. I was there, since 2003, trying to work on this and convince some of our medical people that we needed these pancreatic enzymes. I know we've come a long way, I hope, from that time, and I hope it's much better accepted than it was at first, and people don't have the problems. I think cost is always our biggest issue, and so continuing to work with that area is very important as well. So,
yeah.
Marianne,
thank you.
Thank you.
So we also have a question of what recommendations do to help with future bowel obstructions? Many of us GIs have bowel obstructions. What kind of foods and stuff like that do we avoid?
Some of the most important thing is to reduce the insoluble fibers, and those are the fibers that are associated with the skins and the peels of fruits and vegetables. They tend to increase the blockage. Also, gristly meats. Sometimes we used to talk the minute steaks, so the gristly meats. Those things can cause some problems as well. Too many, sometimes we try to get too healthy and we get into too many of the fibers. So it's real important that we keep that fiber under check. Usually the recommendation is for a low fiber diet, and that's usually what you'll be put on, would be considered a low fiber diet. And this would be 12 grams or under, around 12 grams. And those really need to be more soluble fibers, and soluble fibers are the fibers that come from the inside of the fruits and vegetables. And those have pectin and things that help absorb water in the GI tract. So they can be very helpful for those that have to do the low fiber, to use more of these that are better tolerated. And they also are good energy sources usually as well. So I do encourage that.
Okay, so the next question was, should we follow a high protein or a high fiber? So what you're saying is that we should follow a high protein diet.
Well, we need a high protein diet. we do need a higher. I wouldn't say. I mean, everybody in oncology. I think that we need the more than an average person. It doesn't have to be extreme, but I tend to in practice. I found that really spreading that protein out through the day may even be more important than the amount that you get in at a meal. And it's because we do have an emptying time and our transit time and may not be able to get all the nutrients we need at one time. So I try to put 2 to 3 ounces of a protein source with my larger 3 meals and 1 to 2 ounces with the snacks throughout the day, which are usually in between those and before bedtime. It's very important that you keep those things going at a good pace. But also fiber, you don't want it to, if you're tolerating, if you're not having those bowel obstructions and you're not having GI problems, get that fiber up. Try to get it up in a reasonable fashion. Normal amounts is 35 grams, so you don't have to get that high, but do try to work on keeping it up.
Okay. Now, should carcinoid patients take niacin? And I heard that niacin sometimes causes flushing.
Niacin has been controversial in some areas, I think, for a long time. And it's because it has the flushing and some of the longer actings. And Dr. Odo probably help me with this. It stores in the liver, and we don't want things to store in the liver. So I think that there's some things. But let's talk about niacin from a deficiency point. When people are first diagnosed, that is when we're going to see the biggest problem with a niacin deficiency. There was a recent study, and it was a small study, but at least we're getting some of these nutrition studies. So I'm excited about them coming out of Europe. And we'll talk about another opportunity that I was given that'll help with what we're doing. But it showed that there were, it was a small study, 36 people and a 24-person control. But they did show that 10 of the 24 that showed deficiency in the niacin, one of them actually did have full pellagra. So I think that it's something we need to check as we can. We need to watch the levels. And initially, you want to put it down, put it back, rebuild it, the deficiency. The WHO's recommendation, I believe, is 300 milligrams for a true pellagra, but you would want to spread this in small amounts throughout the day. And that's the key to niacin. If you're going to take niacin, it needs to be in smaller levels, so that you don't have the effects. I usually in practice, I see so many other problems with the B vitamins that I tend to use it with just a B complex and a water soluble vitamin. And most of my patients tend to be someone that has a nutritional concern, and I use multivitamin that may have it as well, and maybe both, but not too much of either one. Just a moderation with that.
Moderation is key, right?
That's right.
What's the best reference for foods to avoid for your 5-HIAA test, urine test? Now, when we have the urine test and we have the blood test, do we have to follow for the blood test the diet?
They're not making the labs do not recommend, and I don't think any of us there's a recommendation, and that's one reason it makes it easier is because we don't have the interference. We don't believe at this time with the levels. I'm not saying medicine doesn't change, and I'm not saying that will never come up again. But at this point, it does look like it's a lot. It's a simpler test because you don't have to avoid things. The urine test, you needed to restrict certain foods, typically high in tryptophan, but for 72 hours. And these, the lists tend to be a little bit different. I've seen the list get very, very long and bothersome, and probably these are foods that most people won't consume anyway in high volumes. But we do have some of the nuts, walnuts, pecans, some of the seedy, especially seedy vegetables, tomatoes, eggplants, cantaloupe, avocados, things that get softer when they get ripe. Pineapple, bananas. And I'm going to tell you what to do. You really need to get this list is available on so many of our sites and your lab. Get your physician's office to print you off. Most of us have the handout of the foods they want you to avoid. And also remember that this medications, over-the-counter foods medicines can affect this, as well as caffeine. So
Right.
there's things to think about when you're taking those urine tests. So be sure and get the handout in plenty of time so that it's hard to collect that urine. So don't waste it. Be sure and make that you do have, and then follow it.
Okay, thank you. And are foods high in aminos important for all neuroendocrine patients to avoid?
Now, amino acids are the building blocks of proteins. So as a whole, amino acids are very, very good. But the amino acids that we know that cause trouble are the ones that are related to serotonin. And these are tyramine, which is amino acid that you find from the aging process of foods. So as things are foods that are smoked or aged, and will have this effect and form tyramine. And also some of the tryptophan foods may also affect. Also histamine foods, which can be tomatoes and some of the tomato paste. But these, and then there's some things that I also am concerned with, and that's like MSG replaced in our foods, because it causes flushing regardless of whether you have neuroendocrine tumors or not. And I think that it's hard to tell why we're flushing, and we sure don't want to confuse the systems any more than we have to. But I'm not sold that these don't cause a problem as well. So it's aged foods and then storing foods quickly. Get them in the refrigerator and stored to reduce the production of these amino acids as well. But no, if you're not having symptoms of flushing, then you really do not have to watch these. So it's all based on your symptoms. And we base the diet based on the symptoms that you're having. So not for everybody, but if you're having those sudden carcinoid syndrome, this is where syndrome is different from just having the tumors. If you're having syndrome, then you may very well need to reduce this list.
Okay. Now, I know there's a lot of talks about what the 5 E's are. I know here in the U.S., we always talk about the 5 E's. I know over in Europe and other countries, they don't talk about it. They don't believe that these 5 E's are important. But can you just go over what the 5 E's are?
I can, and I am, and that was one of the things, Marianne, that I'm doing right now is I'm working internationally with a group of dietitians from Austria, Australia, and the UK, and there's 8 of a big group of 8. I think I'm the 9th one, and we're working on guidelines for neuroendocrine patients. But this is one of the big rubs, and this is where we really don't all have the same agreement, and that's interesting in some sorts. But I will say that some of these are just things that can cause you to do some of these, have some problems. And epinephrine, I think that we see is something that is put in the list. Emotions, how you feel, how you react can cause some of these, we say. Exercise, activity. If you increase the GI tract, or if you're releasing some of these things that can also cause. So you have to be careful, and organize your activities and your exercise. So that's your E. I'm going to have to count my fingers. You know how this goes. So we said emotions, epinephrine, exercise, eating, what you eat can play a part. It's not a huge part as sometimes. And usually it's like with flushing. Sometimes it's with late stage tumors. It's the staging and the amount of tumor bulk in your liver can very much be associated with some of these issues as well. Yeah. So and sometimes if you have a surgery and they get some of these tumors out, we can reset your clock, was what we used to say. I worked with a great team down in New Orleans, and that was always kind of interesting because you would not continue to have some of these symptoms that you had before. And my last E is,
how about exercise?
I did exercise.
How about alcohol?
Alcohol. That's it. ETOH.
Yes.
Alcohol is it can affect flushing and carcinoid syndrome, and I think that's one of the biggest problems. That's where we see it more often. Maybe those European people don't drink as much as we do over here.
I find that hard to believe.
There's several things that are different and things that are unique about American diet, not for the better, probably. I'm interested in, and there is some research coming out of Italy that really associates the Mediterranean diet.
I was just going to ask you about that.
With healthy eating and better outcomes with some of these neuroendocrine tumors. So I'm excited about somebody given us some directions. But what does that mean? It's kind of like saying you have fever in some ways. It's so vague. But a dietitian in the States has done a great job. Amanda Archibald's her name. And she has gone to Europe and gone to these areas where they actually live to be 110 and these regions. And she went and dug into the diet and has done a great job of doing what I try to do. And that's taking nutrition science and making it as easy as putting it on your table. And many times in the diets that I've written through the years, and I do this for Novartis and several of the other companies, a Lexicon, who's published the book, so that we can try to make it simple, because nutrition and what really goes on in your body is a well-oiled machine. But when you throw wrenches in it, like we do to these GI tracts and what we do to the structures and the problems that we have, you need to change some of it. So I'm excited about it. I think she's done a great job of giving us some ideas of things we need to include in our diet, include in our household shopping, utilize in our cooking and in our preparation. Sometimes you've heard me take care of a patient and I talk about texture. I need something chopped up. I need it already mashed. And because I need the saliva in your mouth to start your digestion. So taking these nutrients in forms and what they've done in the Mediterranean diet is really picked out foods that have a real high nutritional value, a nutrient dense food. And done, a good job of maintaining a great gut function. And I think that's where I'm really interested in seeing what the gut function and keeping normal flora is better. And their use of foods that, I like to use in my recipes, like yogurt, they've been fermented to keep the natural flora. So I think that this will be interesting to work with. And I hope that we get interest in it. I've done a couple of podcasts from Marianne and NCAN, and I'd love to do this. And maybe we can have one and really try to do this. Put some of the foods that I think are important in your diet and very nutritional values that probably you might not be utilizing yet.
Yeah.
Sometimes we have to make it simple and easy for your body to digest. And this may be baked potatoes and not use the skin. I mean, there's nutritional value to things that are looked upon as not valuable nutritionally. And I think potatoes is one of those. Rice is one with great nutrients, quinoa. So I think that using beets and some deep vegetables, and then there's a world of herbs, and I love the world of herbs. And so this is exciting. So I think we're learning more, and I hope to be able to present this, continue in a way that's helpful.
Well, thank you very much. I am going to leave the screen right now. Leanne, thank you so much. You'll be back up for the question and answer session.